This is the MyHeart.net podcast. This show is produced by Dr. Philip Johnson in conjunction with VitalEngine.com. Please welcome your host, Dr. Alain Bouchard of Cardiology Specialists of Birmingham, Alabama, at St. Vincent's Medical Center, part of Ascension.
So welcome to our podcast on heart transplantation. And with me, my co-host is Dr. Mustafa Ahmed, Director of the Interventional and Structural Program at UAB. We have also Dr. David McGiffin, who is the actually Director of Cardiothoracic and Transplant Surgery Program at the Alfred Hospital in Monash University in Melbourne, Australia. Gentlemen, thank you for agreeing to get together today on this Sunday and Monday morning for Dr. McGiffin in Australia to discuss heart transplant. So we know that despite the advances in pharmacological and device therapies for heart failure, the morbidity and mortality remains high, and many patients progress to end-stage heart failure. Over the last 5 years, heart transplant has become the preferred treatment for end-stage heart failure, with over 90% of heart transplant patients surviving beyond 1 year and more than half beyond 12 years. In children, even, we have more than half of the patients surviving beyond 15 years. Unfortunately, the number of patients with heart failure keeps increasing, while the number of donor organs remains constant. Number of patients on the transplant waiting list keeps increasing, with patients that are older and have more complex disease, and a lot of them are supported by mechanical circulatory support device. So how do we prevent patients from dying while waiting for a heart? How do we increase the donor pool? How do we make sure that every single heart counts and prevent wastage? These are just some of the issues that we'll discuss today in our podcast on heart transplantation. But first, let's start with Dr. McGiffin. And David, if you could tell us what is a heart transplant and how do you actually take someone's heart and put in someone else's body? And if you could start by giving us a little bit of historical perspective and start in 1967, Dr. Christian Barnard in South Africa with the first heart transplant. David.
Thank you, Alain. The history of the early days of cardiac transplantation are really very interesting, and it didn't start with Christian Barnard. In fact, the early experimental work started with Charles Lindbergh. Charles Lindbergh, who flew the North Atlantic, teamed up with Alexis Carrel at the Rockefeller Center in New York, and he was very interested, well, they both were very interested in perfusing organs and the technology that underpinned that. And that really was the start of interest in mechanical circulatory support that underpins cardiac transplantation, all organ transplantation, and cardiopulmonary bypass for heart surgery. But the first heart transplant that involved a human was very close to where you guys are now sitting. It was in Jackson, Mississippi, when James Hardy in 1964 performed a heart transplant. He sort of had a tremendous amount of criticism for this, but the recipient was somebody who we wouldn't even consider for heart transplantation these days. The patient was had end-stage hypertensive heart disease, had a gangrenous leg. The criteria for brain death had really not been established at that time. And there was a potential organ donor in the intensive care unit. This is in the University Hospital in Jackson. And they felt that, for reasons that aren't completely clear, that this donor heart could not be used. So the recipient was in the operating room. They amputated the recipient's leg, and they didn't have a donor. So Dr. Hardy took a poll around the room with the other surgeons about should we use a chimpanzee heart. because they had chimpanzees that they were using for experimental work. He took a poll. There was one abstention and a couple of proceeds and a couple of reluctant proceeds. So they went ahead and put a chimpanzee heart in this patient. But the chimpanzee heart was very small and couldn't support the circulation for more than a couple of hours. Of course, the patient expired. But that was the first heart transplant involving a human in Jackson, Mississippi. There's a lot of very interesting work that was done because nobody really understood whether a human heart could actually be transplanted and would actually work. And a lot of people aren't aware of this, or very few people aren't aware. There was actually a human heart to baboon transplant. There were two of them. It was done in Virginia. It was done by Richard Lauer in 1967. At that stage, renal transplantation was underway, and there was a donor where the kidneys were being used, and the renal transplant surgeon suggested to Richard Lauer that there was this heart there that was available for whatever he wanted to do. So he took this human heart and put it into a baboon, and it worked. He got a bit worried about the propriety of what he was doing and terminated the experiment, but actually did another one. And this human heart survived in this baboon for 4 days. Now, as concerning ethically that experiment might have been to us now, it's really important to realise that was unequivocal evidence that cardiac transplantation would actually work. Now, the first heart transplant from a human donor to a human recipient was Christian Barnard's transplant in 1967. That was actually because there were no established criteria for brain death and taking organs from a beating heart donor. That was actually a DCD donor, that is a donation after circulatory death. So they had to wait. They had to take the donor off a ventilator and let the heart stop, just as we do now with DCD donors. And then take the heart and transplant it. And that heart struggled for a while, but in fact, it was able to. That they were able to separate from cardiopulmonary bypass, and the recipient died about 18 days later, and died of probably over immunosuppression. But that was the start, and there's a very interesting book that details what was a very interesting race at that time to do the first heart transplant. And the book is called Every Second Counts, and it's a fascinating story about a worldwide race to do the first heart transplant. Christian Barnard did a second heart transplant on a dentist in South Africa, Philip Lieberg, who survived about 18 months and then died of coronary allograft vasculopathy. And there's a famous photograph of Philip Lieberg swimming after his heart transplant. It's not. There's an interesting backstory there that he probably that was not quite as it seemed, because apparently he was very disabled after this transplant. So a group of his friends sort of put him in the water and stood back. Photographs were taken, and they went and grabbed him before he drowned. But anyway, but this was the start of heart transplantation. Adrian Kantrowitz did a transplant. He was in New York. That patient was a child and only survived a few hours. And then Dr. Shumway, who very rightfully is really the father cardiac transplantation because he did so much of the experimental work that underpins modern cardiac transplantation. Did a heart transplant, that was the third heart transplant. And then, not surprisingly, Dr. Denton Cooley did a whole series of heart transplants, including a heart transplant from a sheep to a human. That was, of course, unsuccessful. But the results were very poor worldwide. And there was really a moratorium on heart transplantation because survival was so unacceptable. Except a couple of centres kept going. One of them was Stanford. One was La Pitié in Paris and Papworth in the UK. And it was because they kept going and were the real pioneers of cardiac transplantation that they started solving a lot of the problems of preservation of the donor heart, diagnosing acute rejection, trying to select who they thought was the best recipient, and trying to get a regimen of immunosuppression, and then of course, and that's how cardiac transplantation advanced. And of course, one of the other important things that had to be decided was the issue of the diagnosis of brain death. And until that was done, there were surgeons who were actually at risk legally. There were cases of for example, there was a surgeon in Japan who in 1968 took the heart of a donor who had drowned and transplanted the heart, and he was charged with manslaughter. That cast a long shadow over cardiac transplantation in Japan. It was a long time before the charges were lifted. There is another very interesting transplant called heterotopic heart transplantation, or piggyback heart transplantation, which was started by Christian Barnard. And that is, you leave the recipient heart in situ and put the donor heart in parallel. Now, the reason why that started was because of the very long ischemic times in South Africa, and they needed the recipient heart to support the donor heart until it recovered from the long ischemic time. One of the indications also for heterotopic heart transplantation was where there was irreversible pulmonary hypertension. So that the theory being that the recipient heart, which had the recipient's right ventricle, which was already primed for the pulmonary hypertension, would supply the blood through the pulmonary circuit, and it was the donor left ventricle that supplied blood to the systemic circulation. And in fact, that sort of worked. And we actually, a long time ago, did a couple of these heterotopic heart transplants at UAB. But heterotopic heart transplantation is now gone because the indications that were used then for heterotopic heart transplantation have really now disappeared with mechanical circulatory support and continuous flow pumps. But the real advance in cardiac transplantation, in survival in cardiac transplantation, was the advent of the calcineurin inhibitor drugs, cyclosporine, tacrolimus. The results improved overnight. It was dramatic. I started cardiac transplantation pre-cyclosporine, so I saw it. The results just dramatically improved. Now, there are lots of other things that improved too, but cyclosporine made a huge difference to the results.
That's great, David. So how do you actually, as a transplant surgeon, how do you actually, this is a very long operation. I mean, you're talking about, it could vary from 4 to 10 hours. How do you actually do that? I mean, how do you do the transplant?
Well, the whole the whole mechanism is sort of similar all over the world. There are sort of individual variations, but this is the process in general. So we have a waiting list of potential recipients, and I will say that probably 70% of our patients on our waiting list have an LVAD, and that's probably the same in most large cardiac transplant programs all over the world. So a donor is identified, and there has been determination that the donor is dead by the relevant laws in that jurisdiction. Then there is consent from the family, and then so that is now we have a donor. So then there's a process to match a recipient and make sure that there is adequate cardiac function. So all the investigations such as an electrocardiogram, an echocardiogram are performed to demonstrate there is a good cardiac function. An electrocardiogram is important because very, very occasionally you'll find abnormalities that need to be dealt with. For example, we see patients with donors with WPW. It's very, very common to find a lot of non-specific ST and T-wave abnormalities on the donor electrocardiogram, which are just a feature of brain death because at the time of brain death, there is this tremendous release of catecholamines during the Cushing response. Then we've established there's good cardiac function. In patients with who are at risk of coronary artery disease and male donors over 50 years of age, male and female donors over 50 years of age, we require a coronary angiogram. And then the matching that goes with the matching process involves, of course, blood group. We have to make sure that there is no antibodies in the recipient that would react with donor cells, which could predict a hyperacute rejection. So blood from the donor hospital is brought to the recipient centre, and that is determined. The patients are particularly at risk of having what we call a high PRA, where they've got a large number of antibodies that could react with a wide variety of antigens in the donor. Would be patients with previous pregnancy, previous surgery, previous transplantation. We then have to make sure there's an appropriate size match. The big concern is transplanting a heart from a small female into a large male, which is something we really try and avoid. So we then established that there's that matching, size matching, blood group matching, antibody antigen matching, and a team is then dispatched to the donor hospital. And it's invariably in association with procurement of the liver and kidneys, and often the pancreas and the lungs. So it's has to be a very coordinated exercise to have each team in the operating room and teams that have never met before. Now that's a bit different in Australia because Australia is such a numerically, in terms of population, such a small country, so there are only a few teams, so everybody's met everybody else before. But in the United States, for example, teams will be working together that have never met before. But it's such a well-orchestrated operation now that sort of thing can happen without any disagreement. So then the heart is preserved. The heart is preserved by infusing what's called a cardioplegic solution, which is a high potassium solution to pharmacologically paralyze the heart and cool the heart down. The heart is excised, and then it's transported back to the recipient Hospital. And one of the important considerations is what's called the ischemic time. The time from when the heart is removed to when it's beating again in the recipient. And we need to make that as short as possible because there's a very, very clear relationship between increasing ischemic time and decreased function of the donor heart in the recipient. And that relationship is magnified by increasing donor age. So let's say the safe ischemic time for a 20-year-old donor heart is somewhere around about 5 to 6 hours. But let's say a 50-year-old heart, it's about 3 to 4 hours. So that's an important consideration. So that to minimise the ischemic time, the recipient operation has to be underway when the heart is coming back. And the ideal timing is that the donor heart comes into the recipient operating room as the recipient heart is being excised. Now, that doesn't always work out that way because a lot of these these heart transplants can be pretty complicated, particularly if you've got to explant ventricular assist devices or they're complex congenital heart disease. Most of these patients have had previous cardiac surgery. So often that timing becomes a little bit challenging. Then the actual technical aspects of sewing a donor heart in is very straightforward. There are much more complicated and difficult operations in cardiac surgery than a heart transplant.
David, before you get into this, is there kind of an ex vivo kind of a perfusion system that you guys use to preserve or prolong or reduce the ischemic time on the donor heart?
No, but that's one of the really interesting areas now in all organ transplantation, and particularly heart transplantation, is to increase the ischemic time without the penalty of this phenomenon of primary graft dysfunction. Primary graft dysfunction is one of the very important complications that increase morbidity and mortality after cardiac transplantation. And primary graft dysfunction is often unpredictable and often requires recipients to have mechanical circulatory support, such as ECMO, for a period of time until the heart recovers. And that just contributes to mortality and morbidity. So there are two ways, two sort of machine perfusion strategies that are currently under investigation. The first one is a transmedics machine. And the transmedics machine allows the heart to be beating, and it's warm, and it's perfused warm. That machine is used for DCD donors, and it's donation after circulatory death. So I'll just clarify DCD donors first. So brain dead donors where there's been a neurologic injury which has resulted in brainstem death, and so satisfies all the legal requirements for declaration of death. So so we can proceed then with removing the donor heart, and it's beating up until the time that the cardioplegic solution is given. DCD is different. These donors have had a profound neurologic injury, but they are not brain dead. So you can remove the endotracheal tube and they'll continue to breathe. So because they don't satisfy the criteria of brain death, we can't use the standard brain dead pathway. So what we do in those circumstances, and this has really been pioneered by St. Vincent's Hospital in Sydney. What is done is that all life-supporting therapy is withdrawn. So inotropes are stopped, endotracheal tube removed, and the donor dies. Now that sometimes it doesn't progress, usually does, and it usually progresses because the upper airway occludes. When that happens, the heart stops. Now, there are certain legal requirements. There's usually a standoff period after the heart stops. And as soon as that legal requirement or that standoff period concludes, which is usually somewhere either be 2 minutes or 5 minutes, depending on the jurisdiction, the donor is brought rapidly round to the operating room, the chest opened, and the heart removed and placed on this transmatic system. Now, it's a lot more complicated than that, but that's basically how a DCD heart donor is concerned. We have a very long history at the Alfred using DCD lungs, which work just as well as lungs from brain-dead donors. We don't currently do DCDs because the transmatic system is very expensive, so we've got that consideration. So that's for DCDs. Now, there's a lot of interest in what's called hypothermic ex vivo perfusion, and I've been very involved in this experimentally. And I think this is the next horizon in cardiac transplantation, being able to extend the ischemic time. I'm not talking about for an hour. I'm talking about for 8, 10, 12 hours without the penalty of primary graft dysfunction. So there's a machine that we're investigating as a consortium in Australia of the Alfred, St Vincent's, and a research group in Brisbane, up in Queensland, where we have a model of brain death in sheep. And the donor heart is removed and placed on this machine. So it's at a temperature of 8 degrees, so it's not beating, and it's perfused with a cardioplegic solution, and I think this is the huge conceptual leap, that is a surgeon in Sweden named Stig Steen made this conceptual leap by saying that a heart on a perfusion system is equivalent to a heart in a brain-dead donor. That is, neither have a functioning pituitary gland or vasomotor center. And so in this cocktail that we perfuse the heart are brain death hormones. A little bit of epinephrine, norepinephrine, a little bit of cocaine to prevent reuptake at the synapse, so we can use very low doses. T3, T4, insulin, corticosteroids. And then what we're doing in Brisbane, so we take a heart and put it on a perfusion system for 8 hours. And then I transplant the heart. And these hearts work normally, absolutely normally. So we go ischemic times of 9.5 to 10 hours with normal function. And it is one of the most remarkable things I've ever seen. And it's even more complicated than that, because if we use our usual cold static storage, that is, we take the heart, put it in ice slush, and then, which is what we do every day in cardiac transplantation. And you take a heart from a cold static take a cold static stored heart and put it into a recipient sheep. It has a profound effect on the recipient sheep, that the kidneys stop, or the urine turns black, and the sheep becomes vasoplegic and needs lots of inotropic drugs. Whereas if we use transplant a heart that's been on the perfusion system, even for a couple of hours, the recipient behaves totally differently. So something comes out of these donor hearts, we don't know what it is, that affects the recipients. And I think we see exactly the same phenomena in humans. That is, it's the right ventricle that becomes dysfunctional, and often the urine, they become vasoplegic, and often there is renal insufficiency. So I think the next horizon in cardiac transplantation is hypothermic ex vivo perfusion. You could prolong the ischemic time many, many hours. And it also, I think it has potential beneficial effects on the recipient by stopping whatever it is that comes out of donor hearts when we perfuse them by cholestatic storage.
It's fascinating, and you can imagine the repercussion of prolonging ischemic time with, for example, a patient here in Birmingham not quite finding a match for several months to years, within the transplant center here within the city, but yet could have a heart available in Atlanta, in New York, or even at some other parts of the country. I mean, this would really kind of increase the availability of hearts and increase the potential of transplanting more patients. I mean, this would be phenomenal in terms of the clinical repercussion, and may help, diminish this demand, to supply ratio.
Yes, and in fact, we are starting a clinical trial in Australia, because Australia is the place to start to do such a trial because of the huge geographical distances. This trial is all ready to go, but it's been, of course, can't start at the moment because of COVID. But this is the plan. There are 5 heart transplant programs in Australia, and we're also New Zealand are going to be part of this now too. And if there is a donor heart anywhere in Australia where the projected ischemic time is 6 hours or greater, then the heart will be put on an ex vivo machine and brought to whichever transplant centre in Australia or New Zealand is going to use the heart. And we've actually been in discussions with Qantas, the airline, Australian airline, that this will be flown on a scheduled flight, because we don't have the pressure of time that we currently have with cholestatic storage. Now, all the bits and pieces are in place to start this trial, but unfortunately we can't. But we're hoping that as soon as COVID disappears, then we can start this trial. And I think this will be a very, very important trial to demonstrate that we can safely extend the ischemic time 6-8 hours and take hearts from donors in remote parts of Australia and ship them to New Zealand or vice versa.
Fascinating. We got off track a little bit. Let's go back to the actual surgery that you were just about to start talking.
So it's very unusual these days, but there are occasionally recipients who haven't had previous cardiac surgery, and that's a very straightforward transplant procedure, and that operation would take no more than about 4 hours from start to finish. But invariably, it's patients with complex congenital heart disease, multiple previous operations, or they've got an LVAD, or they've had previous cardiac surgery as an adult, coronary surgery, valvular surgery, and so on. And so those operations can take considerably longer because they're often associated with destabilizing bleeding. And that's one of the important considerations doing a heart transplant, where there might be a potentially long ischemic time, either because of the travel time or a longer implantation time. And when we after we reperfuse the donor heart in the recipient, if the preservation hasn't been ideal, if there's primary graft dysfunction, and then you add to that destabilizing bleeding, then that can really impact the patient's post-transplant course and increase morbidity and mortality. So part of the calculation that we've got to make is, for example, we wouldn't use an older donor heart with a long ischemic time in a patient where we are likely to have a very complicated operation, because it's going to set the recipient up for primary graft dysfunction. That's sort of part of the calculation. Then after the operation has been concluded, patient goes to the intensive care unit, And from then on, except for immunosuppression and microbial prophylaxis, the recipient's treated very much as somebody else having cardiac surgery. The process is very similar.
You mentioned there was some difficulties, particularly in matching the size. Now, obviously, in children, particularly that have had congenital heart disease, they're pretty small. You need to match the size there as well. But so you have a small child, and that heart that you just transplanted will grow with that patient, right?
That's correct. Yes.
And but is there actually some difficulties in the congenital heart that have had Fontaine procedure and all kinds of surgical procedure already? Is there like a lot of more scars? Do you have to transplant the lung as well as the heart, or is there more difficulties like that in?
Well, this applies just as equally to adults as it does to children. In fact, more so. There is a people talk about this tsunami of congenital heart disease. These patients, this big wave of patients that's going to come through who have had one or more operations as a child, where the heart cardiac function is going to deteriorate to the point that they need transplantation. So I don't think it's as big a wave as people are suggesting, but nevertheless, it is true that there's going to be an increased number of patients that, for example, have had Fontaine procedures where that Fontaine procedure is going to fail, and those patients are going to have systemic venous hypertension and all the consequences of that, protein-losing enteropathy and liver disease and ascites, and those people need transplantation. And I will say that that's often a real challenge to know that the timing, because the deterioration patient, let's say with a failing Fontaine, is usually very slow over years, and often the people that are looking after these patients don't quite see that this deterioration is occurring because it's so slow. And consideration about cardiac transplantation often comes a little bit late. And so I will make a point in a patient with complex congenital heart disease who has had, let's say, a Fontaine procedure, who is showing the first signs of a failing Fontaine, systemic venous hypertension, first evidence they might be getting some liver disease. That's the time to be at least getting them to a transplant centre so they're on the books, so the transplant centre is aware of them, rather than what unfortunately happens quite a lot. They're really at the end of the line. They've got protein-losing enteropathy, they're cachexic, the ascites. The liver disease has proceeded beyond just fibrosis, and now it's cirrhosis. They've got collaterals, and they've got plastic bronchitis and all these complications of failing Fontaine. So now what happens is that the risk of transplantation increases dramatically. And yes, we may still go ahead and do the transplant, but we're in that sort of ethical dilemma about, do we allocate a good donor heart to somebody whose risk of transplantation is inordinately high when it could have gone to somebody of lower risk who's likely to get a better result. So yes, the operations can be technically more challenging, the post-operative management more challenging, but I think the bigger issue is getting them referred at the right time before we get into this situation where we've inadvertently increased the morbidity and mortality of the operation. You mentioned, do we have to transplant the lungs? Well, that's sort of a really interesting issue, because these days heart-lung transplantation, which used to be relatively common in the early days of transplantation, is now a very rare operation. Last year, there were 75 heart-lung transplants worldwide. Often, the reasons for doing a heart-lung transplant, even in the old days, have disappeared. For example, with people with pulmonary vascular disease associated with with the end-stage heart disease, those patients would not be transplanted. They'd get a ventricular assist device. And then, as the pulmonary vascular disease regresses, then they can have cardiac transplantation. So they don't need a heart-lung transplant. And also patients with, say, pulmonary arterial hypertension with a very, very adversely remodeled right ventricle, in the old days, we would do heart-lung transplant. We know that's not necessary now. We will do a lung transplant, and that right ventricle will recover. It won't ever be normal, but it'll recover. And so at the Alfred, we do about one heart-lung transplant a year. But that raises another issue. How do you train surgeons to do heart-lung transplants these days? So it's only the sort of transplant surgeons of my vintage who have done many of these operations. And so it's very difficult to train a young surgeon to do a heart-lung transplant, because often these heart-lung transplants can be very challenging operations, particularly when there are multiple aortopulmonary collaterals. And there are some real technical tricks to avoid what can be fatal bleeding doing a heart-lung transplant.
So, David, you've talked a little bit about the procedure. You talked about the match and everything. In the United States, we have between 3,000 and 4,000 people on the waiting list, for a heart transplant. Particularly with this COVID situation that we have now. Could you describe a little bit, if I'm a patient on the waiting list, what is the relationship that the patient has with the transplant team? What is the transplant team composed of? How do you do the visit? How do you stay in touch, nowadays?
I'm sure there are differences between countries and programs and how that's all managed. At the Alfred, those patients on the waiting list regularly visit the transplant cardiologist. We make sure that there is no emerging contraindications to transplantation. At the Alfred, in Melbourne, we also have responsibility for transplantation in quite distant areas of Australia, in other states. So we can't bring those patients' clinic visits to Melbourne. That wouldn't be reasonable. So we do rely on cardiologists in the other states to manage these patients while they're waiting for a transplant, and then let us know if there are any major deterioration that might contraindicate transplantation. But of course, the issue here is, should these patients proceed if they're deteriorating to ventricular assist device implantation? So patients that are on the waiting list but are deteriorating, those are patients that we would consider for a ventricular assist device transplantation as a bridge to transplantation.
So the COVID period, we've noticed that the heart transplant number has plummeted here in the United States just because there were so many patients being treated with this infection in the hospitals. I'm sure you observed the same in Australia. As it started to recover, have you seen in your center a recrudescence of heart transplant activity in your place?
No, we haven't, because in some states in Australia, we're currently undergoing a second wave of COVID. So the number of organ donors has decreased, and because people aren't going out and doing the activities that often turns them into donors. There are borders between certain states that are shut, which complicates procurement. Now, we can go, but we also have some concerns about exposing our team to potential transmission in other hospitals. So we rely on the availability of surgeons in that state to be able to take hearts for us. And that's not always the case. So transplant activity has dropped very substantially in Australia.
Hopefully that won't be too much longer. But let's say the patient has had their surgery. They're in the hospital now. How long do they stay in the hospital? What is the recovery period? What does it mean actually to have had, a heart transplant after the surgery?
So hospitalisation is usually somewhere between 10 and 14 days at the Alfred. That I'm sure that there are other places that may aim for a shorter stay. We've not been particularly we're not under any pressure to shorten the stay, but I'm sure in the US there are all sorts of financial pressures to make that stay as short as possible. That's not the case in Australia. Then the patient is seen very, very frequently at the transplant centre, at our transplant centre for the next 3 months. If they're from outside our state of Victoria, then they are required to stay in Melbourne for 3 months before they can return to their home state. And during that time, endomyocardial biopsies are performed on a weekly basis for the first about a month before it then becomes monthly. But of course, that's also determined by the appearance of acute cardiac rejection, so that biopsy schedule changes if there's rejection, and then we need to make sure that the treatment's been effective. And of course, there's monitoring of their of all their usual blood work, renal function in particular, and optimization of their immunosuppression.
So what kind of medication, you mentioned cyclosporin, what kind of medication is the patient placed on after transplant?
Yeah, so I'm going to simplify what is a really complex regimen. So they're on a CNI, that is a calcineurin inhibitor drug, and these days it's usually tacrolimus. There may be some reasons, which I won't go into the details of, but there are some reasons why sometimes we'll use cyclosporin rather than tacrolimus. They're on a cell cycle inhibitor, mycophenolate, and they're on steroids. Now, there are certain times when we use a proliferation signal inhibitor, such as everolimus, in place of a CNI, but that we don't need to go into those details. They're also on antimicrobial prophylaxis for depending on their CMV status. If they've, for example, they were CMV negative and received a CMV positive donor, then they're on a regimen of antiviral drugs, and they're on Bactrim as prophylaxis against PCP. Although that name is now changed, it's now JCJ, I think.
So, obviously there are some risks after the heart transplant. You mentioned infection, you've mentioned rejection, and also you've mentioned the cardiac allograft, dysfunction or failure. Can you actually talk a little bit more about those? If you have a rejection, for example, how does that manifest itself? What does the patient feel? What are the symptoms, of that, and how do you treat it? And
so the overwhelming majority of rejection episodes are diagnosed by a protocol endomyocardial biopsy and are asymptomatic these days. And I think that's one of the things that the CNI drug has done. It's sort of changed the pattern of rejection. Before cyclosporin, there was a lot of edema in the heart, and which contributed to myocardial dysfunction, and the patient became symptomatic, they became fatigued and short of breath, and we knew rejection was occurring, but we don't know when it's occurring occurring clinically now with a CNI. So the diagnosis is made on endomyocardial biopsy. There's a grading system, depending on whether it's just a cellular infiltrate, whether there's actual necrosis of myocytes. And that's, of course, once we start seeing necrosis of myocytes, then that's a more severe episode of rejection. And the usual way of treating rejection is just to give a bolus of steroids. If it's persistent rejection, in other words, it's still there on a repeat endomyocardial biopsy, or it's recalcitrant, we just cannot get rid of it, then we may use anti-lymphocytic drug, an antithymocyte globulin of some description, to eradicate the rejection episode. I will say, I should have mentioned that when we're talking about immunosuppression. There is a drug that that probably most centers in the US give up front. It's a very expensive drug, so we have to be a little more careful with it, which is an IL-2 blocker, daclizumab or basiliximab, and it's made a real difference. This is about induction therapy. There's a lot of interest in induction therapy. Can you prevent rejection from even occurring by giving this induction drug first? There are many years ago, before cyclosporin, we used to give ATG up front, which we don't do now. But the IL-2 blocking drug tends to delay rejection. So one of the problems with the CNI drugs is that they are nephrotoxic. And if you've got a patient who's got primary graft dysfunction, then you add a CNI, then you can switch the kidneys off. But if you give an IL-2 blocker up front, you don't have to start a CNI for several days, and by which time the graft function improved and renal function is robust. So that's a way with an IL-2 blocker, you can get around the problem of using the CNI up front, particularly in the setting of primary graft dysfunction. So most episodes of rejection can be just turned around simply by a bowl of steroids. Now, there are occasions, it's pretty rare these days, but there are occasions when a patient has what's called a hemodynamically compromising rejection, a HC rejection. That is, they present in low cardiac output, poor cardiac function, and that's a real emergency because those patients are going to die. And so you throw everything at a HC rejection, including steroids, ATG, and plasmapheresis. And the plasmapheresis is not necessarily all about the treatment of the rejection episodes, is to get rid of the cytokines that are responsible for the hemodynamic issues that you're seeing, that get rid of the myocardial dysfunction. They get rid of the cytokines according to myocardial dysfunction. So we don't see HC rejection very often these days, but when it does occur, it's a real emergency. And then there are patients who have ongoing rejection that we just cannot get rid of. And in those patients, we will consider other modalities such as total lymphoid irradiation or photopheresis.
So acutely, immediately after the transplant, you have, of course, the risk of infection and the risk of rejection. Let's talk a little bit about this primary graft dysfunction, where it seems like, I guess sometimes it could present as a mild reduction of the heart function. Sometimes I guess it could be, moderate and it's affiliated with the ejection fraction or the pump function starting to decrease and causing hypotension. And sometimes it could be very severe, like in the case you described that had the rejection, where you need something like to support the heart, like ECMO and so forth. How frequently do you see this graft dysfunction? Can you predict who's going to develop that? Are there some risk factors to get that? And how do you address that? What kind of treatment do we have for this dysfunction?
So primary graft dysfunction is the major cause of mortality and morbidity early after cardiac transplantation. And so that's one of the real challenges. If we get rid of primary graft dysfunction, then the results would improve quite substantially. Because if you look at the survival curves of cardiac transplantation over by era, you see the survival curve potentially progressively increasing, except for early, where there's still that early hazard of death, because we have not made a big impact on primary graft dysfunction. Now, we know that there are certain circumstances where we're setting a recipient up for primary graft dysfunction. An older donor, let's say a 60-year-old donor with a long ischemic time, 4 or 5 hour ischemic time, in a complicated operation where you may get destabilizing bleeding. Now, that's just a setup. And even make it worse, let's add a small female to a male donor. So that's a setup for primary graft dysfunction. But even with the very best size matching, short ischemic times, it still happens. And we don't understand why. And it's not the left ventricle that's the problem, it's the right ventricle. And we invariably see it start in the operating room. So why is it the right ventricle? Well, nobody really knows, but perhaps it may be related in part to the fact that embryologically the right ventricle comes from a different field from the left ventricle. You know, the left atrium, right atrium, and left ventricle come from in the developing embryo, come from a very different field than the right ventricle. And maybe that it's a sort of a cellular problem, but it's invariably the right ventricle, and we frequently have to support these patients with ECMO for a few days before the right ventricle recovers. It eventually will recover, but then you're exposing the patient to the risk of mechanical circulatory support for a few days.
Gene Blackstone did an interesting study, and actually it's a previous colleague of yours. I guess he was at UAB with John Kirkland, when you were at UAB.
That's correct, yes.
Yeah, he did his studies I understand he's at Cleveland Clinic now, and he was trying to look at these predictors of mortality. And it seems like immediately post-transplant, the patient that had pre-transplant mechanical ventilation really were more prone to have problem and an increasing problem immediately post-transplant. And I guess it's understandable, again, pointing toward the ventilation problem, the right ventricle, as you mentioned, but also what was important is in patient that had already some end organ dysfunction, whether it was the liver and their bilirubin, or whether they had already some renal failure or renal impairment, tend to have more problem immediately post-op. Is that
yes? Absolutely, and it's not necessarily the ventilation, but it's probably the reason why they're ventilated. So the ventilation is a surrogate for low cardiac output. Now, so in somebody who's got deteriorating circulation to the point that they've got end organ dysfunction, what pathway should that patient be on? Should they go straight to cardiac transplantation, or should they go to a ventricular assist device? So the information on that is in and pretty clear. They should go on a mechanical, go to a VAD, so that end organ function can recover, and then they can have a transplant. That information is pretty clear from the experience with cardiac transplantation in Spain, where because of the organ allocation system and the brain death laws and the opt-in. Let me back up. So the information is in on the results of transplantation on patients with serious subsystem dysfunction, and that is the results substantially inferior to transplanting patients where they have normal subsystem function. So those patients should not undergo transplantation where they have subsystem dysfunction. Ventricular assist device, recovery of subsystem function, and then transplantation.
I think that was also his point. I mean, particularly that there's an impetus to doing more patients. Actually, the acuity has been raised to patients on ECMO, leading them to a heart. But you have to make sure that the patient stabilized to some degree, having some recovering of their liver as well as kidneys before going to a transplant.
And the same thing applies to ventricular assist devices. That if you've got a crashing patient, cardiogenic shock, those patients should not go to a ventricular assist device. They should go to temporary mechanical support, such as ECMO or temporary VADs, until they have recovery of self-system function, and then have a ventricular assist device. And so the same thing applies to transplantation.
Well, there is another risk of post-transplant, and this is vasculopathy. Patients developing coronary artery disease. I mean, so that's why I really like to have the input of Dr. Ahmed, who probably is involved doing all the yearly arteriogram on these patients, because obviously, their hearts are denervated, so they don't feel any chest pain or any angina like our normal patient. What is the protocol that you follow at UAB, Mustafa, to really kind of detect and treat this vasculopathy or the development of blockages in the arteries of the new heart?
I was enjoying just listening to this this expert commentary. So, Dr. McGiffin, you jump in, with anything different, but these are watched very closely. The surveillance is done every single year almost when it comes to looking at the arteries, and you can get aggressive forms of the same vasculopathy that can affect the rest of the heart. You can get this occur to a severe degree in the arteries, and I guess the stakes are so high when you do cardiac transplantation that you do what it takes to try and keep that that transplant viable. And so one thing is, the rest of coronary artery disease, when the patient normally has a artery blockage, say 70%, and that was just someone without a heart transplant, you would come into the hospital and you may or may not use, different tools to try and see what does that mean, measuring pressure across the blockage, or maybe putting a camera in and looking at that. My experience of dealing with vasculopathy from cardiac transplant is it's much more aggressive, the treatment of it. You're much more likely, and again, this is done in a multidisciplinary fashion. This is after, each case is discussed with the surgeons, the heart failure cardiologists, and ourselves. But it seems to me there's always a much more aggressive treatment strategy. Blockages will be stented earlier. Surveillance will happen more often. Rather than rely on non-invasive tests, there's more of a, less of a threshold to just jump ahead and look at an angiogram. And so, the usual methods, stenting, management of development of arteriosclerosis, but I imagine a lot of that is also to do with the immunosuppressant regimen and that. Dr. McGiffin, do you have anything to kind of add to that? I will tell you, our role as interventionalists is really to discuss with the multidisciplinary team and just be available to do that aggressively. What are your thoughts on that? Have you done bypass, for example? Have you had to do bypasses on cardiac transplants?
I have, but let me just talk about the pathology here. So cardiac allograft vasculopathy is a very different pathology from traditional non-transplant coronary artery disease, which is non-transplant coronary artery disease tends to be discrete and segmental, whereas cardiac allograft vasculopathy is the diffuse process involving the microvessels as well. And as Alain pointed out, patients with cardiac allograft vasculopathy don't usually get symptoms, although reinnervation of the transplanted heart can occur. It's extremely rare to actually get chest pain. Usually these patients are presenting with heart failure, fatigue, or sudden death when they have severe disease. So you're absolutely correct. The threshold for intervening on cardiac allograft vasculopathy is a lot more aggressive than with non-transplant coronary artery disease, because we know that patients are not going to experience symptoms, and that the natural history is for it to progress. And for severe cardiac allograft vasculopathy, the most effective therapy is retransplantation.
I remember when I was in Paris with my friends, Marie-Claude Maurice and Thierry Lefebvre. They had some patients, young, in their teenagers, that had a transplant. And that was back in the days where a Cypher, a coronary stent, it was the first drug-eluting stent that we have. These patients had a coronary stent, and they were reblocking, these stents within months. It was really unbelievable. I guess there are some potential, or future treatment with maybe drug-coated balloons, maybe that could help. But it is such a systemic disease, and it's so aggressive. The rate of restenosis of these arteries, that probably the ultimate treatment is a retransplant in these patients, as you said.
Yes, although it's the microvascular disease that's part of this picture of cardiac allograft vasculopathy that is one of the problems that make it not such desirable disease for intervention. Now, having said that, cardiac allograft vasculopathy is a major problem. It appears in about 50% of patients by 5 years, but it's not necessarily, that doesn't translate into 50% of patients at 5 years are going to need a retransplant, because in some patients it can stabilize. In some patients it can be rapidly progressive, but that's probably the lesser of the two. And in some patients it can remain stable, but it needs regular surveillance, either by coronary angiography or intracoronary ultrasound, or CT.
Any particular risk factor to develop this vasculopathy? I mean, an older donor heart, or an older recipient, or patients with diabetes?
Yes. Well, there are the traditional risk. There are the traditional risk factors, atherosclerotic risk factors of older donor heart, or older age, and smoking, and et cetera, et cetera. But then there are the other risk factors associated with transplantation that are responsible, such as acute rejection, primary graft dysfunction, which appear in lots of risk factor analyses. So somehow they're related. Now, Mustafa asked a question about surgery for coronary allograft vasculopathy. I have done it, but I suspect that it wasn't cardiac allograft vasculopathy. It was pre-existing donor disease, because it's incredibly rare for cardiac allograft vasculopathy to be amenable to coronary bypass surgery. So it probably was pre-existing coronary artery disease in the donor. Interesting.
So that's why it's so important for these patients to be screened for transplant, because lifestyle modification is really very, very important in these patients. Make sure that obviously they don't go back to smoking, or they don't smoke at all. Make sure they check their blood pressure. Make sure they exercise on a regular basis. You can, after all, have a pretty normal life after a transplant, isn't it? I mean, you can exercise. Women have children? It's a bit more complicated. What kind of normal life do you have?
Yeah, Dr. McGiffin, you've got your own experience with people flying, correct, after transplantation?
That's correct. So quite a number of years ago, I was approached by the Federal Aviation Administration to see if it was possible for general aviation pilots, so this is non-commercial, non-airline pilots, general aviation pilots, to safely fly, because cardiac transplantation is a disqualifying condition for a medical certificate to fly. So we did a very sophisticated, detailed analysis at UAB when I was there, based on the cardiac transplant research database. What's the probability of dying suddenly? And for about 25% of recipients, that risk was incredibly low as normal population. So we established a number of criteria that had to be satisfied. And if those criteria were met, then the FAA agreed that those general aviation pilots could get their medical certificates back to fly. But they had to undergo annual reevaluation. And very recently, I was at the FAA because we wanted to look at all the pilots that have been recertified, and there were in fact 20 of them. And all of them are doing well. There have been no deaths, no aviation incidents or accidents, which is, of course, our major concern. So for those people that those pilots that have had a heart transplant that have satisfied these quite strict criteria, it is very safe for them to get their medical certificates back to flying.
Can you have a pregnancy?
Yes, we don't encourage it, but yes, the answer is it can be done. It can be done, but not encouraged.
Yeah, so I think we can see that, it's so important to have a good lifestyle. Lifestyle modification is so important to prevent maybe the complication like vasculopathy. Now, thank you very much, David. Well, this concludes our podcast on cardiac transplantation. I want to thank David McGiffin, from the Alfred Hospital in Melbourne, Australia, and Dr. Mustafa Ahmed at UAB. Thank you, gentlemen.
To learn more from our team of cardiologists, please visit us at MyHeart.net. You can also follow us on social media by searching MyHeart.net on Facebook and Twitter. And be sure to subscribe to this podcast so you don't miss our next episode.